Okay, we are going to get into chapter 14 with this lecture, all about the spinal cord and the spinal nerves. So last time we did the brain and we talked about its development, all of its functions, the different regions of the brain, and now we're going to go into the spinal cord. So the spinal cord has two major functions. It is a structural and a functional link between the brain and the rest of the body. So it brings sensory input from the body to the brain and then motor output from the brain to the body. There are also spinal reflexes, which operate independent from the brain, and it's a fast reaction to a stimulus. These are typically to retract from some kind of dangerous stimuli, and we'll see that reflexes are evolutionary a life-saving thing. So let's get into some of the anatomy of the spinal cord. So the spinal cord extends inferior from the brainstem, from the medulla through the vertebral canal. There are four different parts, just like there are four different sections to the spinal cord itself: the cervical, thoracic, lumbar, and sacral. The spinal cord itself ends at the L1 vertebrae, so the vertebral column extends beyond the actual spinal cord itself, and that structure at the very end of the spinal cord is this conus medullaris. Now, extending from the conus medullaris are spinal nerve roots called the cauda equina, so they are equina, I guess, and so those are kind of like little hair-like extensions coming off of this medullaris, this actual spinal cord structure. There's also two widened regions with greater numbers of neurons, so these are just collections of neuron bodies. There are cervical enlargements and lumbar enlargements, so cervical obviously is the superior one, the lumbar is going to be the inferior. The cervical enlargement has neurons innervating the upper limbs, and the lumbar enlargement has neurons innervating the lower limbs. And as we go down the spinal cord, that's a general trend that the nerves in the upper portion of the spinal cord will innervate more superior structures, whereas the lower spinal cord nerves are going to be sending out axons for the lower structures of the rest of the body. Here is just a gross anatomy of that. You can see the different structures along with the vertebrae. There's the cervical enlargement, and then down here you have your lumbar plexus and your lumbosacral enlargement right in this area. See if there's anything else. There are a couple of different plexuses that we'll see, which are just groupings of nerves. We'll get into detail on those. Yes. Okay, so just to review, because we're talking about spinal nerves, so what is a nerve? A nerve is a cable-like bundle of axons. So remember, axons are extending from individual neurons, and when you have a big bundle of them, you have a nerve. They are wrapped in connective tissue wrappings, the epineurium, perineurium, and endoneurium. And in our spine, there are 31 different pairs of spinal nerves. So there's one for each side. It's because remember, the spinal cord, just like the brain, will typically innervate the opposite side of the body. So you have one spinal nerve for each side of the body. 31 pairs, 62 total. The name begins with a letter and a number. So there are rootlets that merge to form roots. So directly off of the spinal cord, you have these little extensions, these little smaller rootlets that then kind of merge into one larger nerve, or root rather. The posterior root, and this is something that we'll hammer home, posterior root has sensory neurons, and the anterior root has motor neurons. So posterior structures are going to be sensory, going from the body to the brain, whereas anterior roots are going to be motor, going from the brain to the body, sending out a signal. The posterior root also has this posterior root ganglion that contains the cell bodies of those neurons. So if you remember that a ganglion is just a term for neuron cell bodies. Each spinal nerve forms where the roots join. So when we actually talk about naming a spinal root, it is both the anterior and the posterior sections, both the sensory and the motor sections. So spinal nerves are all mixed nerves. And just I think that's important to remember, because we do get so hung up in dividing and organizing the spinal cord, the spinal nerves and the brain, that it's sometimes hard to think or to remember that, okay, these are all part of one big system. So even though we talk about anterior and posterior, sensory and motor, these all interact with each other. So here is just a representation of that. You see these rootlets kind of directly in contact with the spinal cord, and then as you branch off, you have your posterior root, your anterior root, and then they join to form, I guess over this will be easier, your rootlets, your anterior root, your posterior root, and they join to form the actual spinal nerve. Here's that posterior root ganglion with the cell bodies, and the anterior root, the cell bodies are in the spinal cord itself. It's important, we'll again go more into this, but with our sensory and our effectors, we have both somatic and visceral. So the somatic receptors being those tactile receptors, proprioceptors, giving feedback from our somatoskeleton body, so our physical body, whereas the visceral having baroreceptors and chemoreceptors measuring our organs, our glands, blood vessel stretch, blood chemistry, those kind of things. Okay. So the spinal cord is protected by the bone, meninges, and the cerebrospinal fluid, all those structures of the vertebral canal, of the vertebral column. The cord passes through the canal, and each spinal nerve exits through an intervertebral foramen. So remember, foramen means a hole, and intervertebral, so between the vertebrae. So the holes between the vertebrae, that's where those spinal nerves will exit out, rather. The spinal cord also has the same meningeal layers, or similar meningeal layers, that the brain did. It has the most closest to the spinal cord, the one that's directly adhered to the spinal cord, the deepest one, is the pia mater. It has, in the spinal cord, elastic and collagen fibers, as opposed to areolar connective tissue in the brain. And it also has two different structures. It has denticulate ligaments and the filum terminale, which are just there to help support and provide structure for the spinal cord. Remember, this is all connective tissue. If you remember those lectures that we did on the different types of tissue, connective tissue's biggest function is to provide structure, support, and to house blood vessels. So your pia mater, it's going to have these two structures that are helping to provide structure or to provide support. The arachnoid mater is going to be the one that is just superficial to the pia mater. It will have a subarachnoid space that allows CSF to flow through it. And the dura mater is the outermost one. It's tougher. It has dense irregular connective tissue to stabilize the spinal cord. And it has both the subdural and epidural spaces. So subdural would be between the dura mater and the arachnoid. And then the epidural space is between the dura and the vertebrae. And this is that clinically significant space when people have an epidural injection, usually, especially during childbirth or child labor. It helps to deaden the sensation. They give it at a certain point in the vertebral column, so all sensation below that point is lost, is numbed. Just to take a moment to look at that, right here. So if we spin this guy around, we can zoom in, and you can see how you have these little branches of nerves. That's the vertebrae. But you have these little branches of nerves coming out through those intervertebral foramen, those little holes right between our vertebrae, those nice little giraffe-looking thoracic vertebrae. So if we take off our skeletal system, you can see that you have the superficial meningeal layer, the dura mater. This is going to be your arachnoid mater. And the pia mater is, again, continuous with the spinal cord itself. But if we get in close, you can see here, these are those denticulate ligaments that are branching off the sides of the spinal cord, all up and down its length. The length of the spinal cord. Obviously, it ends at the conus medullaris. Now, also, we had that filum terminale. So terminale, terminal, end, finish. So right here is that filum terminale. You can see it's this most anterior structure right here. This is a spinal cord nerve. It's a spinal nerve. That is the filum terminale. So I'm going to actually put the skeletal system back on, and I'm going to hide the sacrum. And you can see how this filum terminale is going right into the coccyx, helping to, and you know, we can see, oh, there we go. You can see how it runs back up into the spinal cord and then down here to the coccyx to help anchor the spinal cord. Okay. Yep, this is just another cross section of that. You can see your epidural space with your dura mater. Let's see, yeah, the pia mater directly adhered to it. I think it's good. There again is just another view of that. We'll get into this in just a moment, but remember, in the spinal cord, your gray matter is interior, your white matter is exterior, is more superficial. That's the opposite of the brain. Okay, so the gray matter. The gray matter is made of neuron cell bodies, dendrites, and unmyelinated axons. Remember, white matter is white because it has that myelin sheath, which is very fatty. There are masses of that gray matter that is going to project from the spinal cord. You have posterior, anterior, and lateral horns. The posterior horns are going to be sensory, not surprising. The anterior horns are going to have somatic motor neurons, and the lateral horns will have autonomic motor neurons. The lateral horns are only present in the T1 to L2, so thoracic 1 to lumbar 2 vertebrae, that section of the spinal cord. It's the only part that has the lateral horns. So let's see, is it this one? No, keep going. There's a picture of all this in just a moment. So connecting those horns, you have this gray commissure. So remember, in the brain, there was the commissures that connect the two halves of the hemispheres. Your corpus callosum is one of those commissures. So the gray commissure is a horizontal band of gray matter surrounding the central canal. It has unmyelinated axons connecting the left and right gray matters. So commissures connects the left and right sides. There are nuclei, which, if you remember, nuclei are groups of cell bodies. You have sensory and motor nuclei. You should just go ahead and accept that. There's almost always going to be a sensory and a motor. There's almost always going to be a visceral and a somatic. It's going to be divided like that for everything. So the sensory are in the posterior horn, no surprise there. Somatic are receiving signals from skin, muscles, and joints, your somatic body. Your visceral are receiving from blood vessels and your organs, your viscera. Okay. Your motor nuclei are in the anterior and lateral horns, so on the front and the sides. They contain the motor neurons. We're okay with that, motor in the anterior and lateral portions. They have somatic motor nuclei to innervate skeletal muscle, and autonomic motor nuclei to innervate smooth muscle, cardiac muscle, and different glands. Yes. So here you can see this is divided up a little bit more. So you have your posterior root. So again, this is the anterior portion of the body. So this would be the front of the body here. So you have your anterior horn, your lateral horn, and then your posterior horn. Did I do that right? Yes. I had to make sure. So your posterior horns are going to have those somatic sensory nuclei. The lateral horns are going to have the autonomic motor nuclei, and then the anterior horns are going to have the somatic motor nuclei. Okay, so now talk about white matter. So white matter are the myelinated axons going to and from the brain. If you remember that the white matter is going to be transmissive, whereas the gray matter is going to be processing. So think about the function, again, the functions of the spinal cord. One of the main functions is to be a structural and functional connection between the brain and the rest of the body. So for the brain, its main function is processing and interpreting information. So the exterior portion, the superficial portion, the part that's you're going to come into contact with first, if you're a neuron and you're going to the brain, the part that you'll contact first is going to be that outer gray matter that's all about processing and interpreting information. Whereas the white matter is deeper into the brain, and it's all about connecting different parts of the brain to itself. And the spinal cord, because the spinal cord's function is kind of this information highway, this intersection of information and signals and going in and out, its internal portion, the gray matter, where it processes information, is internal, whereas the transmissive portion, the axons, the white matter, is all going, the myelinated axons and the white matter is all going to be more superficial. So that way nerves will come into contact with that first, and signals can be sent where they need to. It's just a slight, try to make sense of why is it structurally different in the spinal cord versus the brain. It's because they have different base functions. Okay, so this white matter, it is organized into different fununculi. Fununculus, you have a posterior funiculus, sorry, I always want to add an extra N in there. Funiculus, you have a posterior funiculus, a lateral funiculus, and an anterior funiculus. So the posterior funiculus, it's going to be between the posterior gray horns, and it has sensory tracts. Nothing weird. Tracts are bundles of axons. It's okay. The lateral funiculus, it's going to have sensory and motor tracts. And remember, this is white matter. So this is not about processing information. This is about transporting information. Okay, so your posterior is still transporting just sensory. Your lateral is going to be transporting sensory and motor. And your anterior is going to also have sensory and motor tracts. We also start to talk about ascending and descending tracts. So if it's an ascending tract going up the spinal cord, it's going to be a sensory signal. If it's a descending tract going down the spinal cord, it's going to be a motor signal. And that is just in relation to the brain. If something is going to the brain, you're not going to have a motor signal going to your brain. You're going to have a sensory signal going to your brain. So that's an ascending tract and a descending tract in your anterior funiculus. Hey, stop. Sorry, my dog. Okay, here is a representation of this. Remember that whatever happens on one side of the spinal cord is going to be mirrored on the other. So they're just showing on this side, they're showing the sensory portions in blue, the motor portions in this reddish orange, but you have them, sorry, I'm pointing my screen like you can see me point. But you know, this anterior corticospinal tract is also mirrored right here on this left side. Rather, that would be the right side. If this is anterior, that would be the right side. Okay, so you have your anterior horns, lateral and posterior horns, and then you can again see these different tracts, these different funiculi that are arranged. I know these have some awful looking names. I didn't name them, sorry. Okay, so these are just the tracts of white matter external to that gray matter. Here is just different representations of how the spinal cord will change as you go down the spinal cord, because again, as you're moving down the spinal cord, you're innervating different structures, you're receiving input from different structures, and so the spinal cord needs to look different to represent that functional difference. Structure and function, form and function, always follow each other. So you can see up here you have a little bit more of this extensive white matter, whereas you get lower and lower, you start to have a little bit more gray matter for more processing different reflexes and things. Okay, conduction pathways, so actually moving signals through the spinal cord. There are sensory pathways that ascend toward the brain and motor pathways that descend from the brain, ascending, descending tracts. They have common characteristics. The pathways are always paired, so there will always be a left track and a right track. The cell locations are going to be pretty consistent. There's always going to be 3 locations for cell bodies. The axons are in the spinal cord tracts. The cell bodies are in the ganglia, the spinal cord horns, gray horns, or the brain gray matter. So with all the conduction pathways of the spinal cord, they're going to be paired. You're going to know where the cells are. They're only going to be in limited portions. Each pathway is made of a chain of 2 or more neurons, so 2 or 3 neurons usually, and then or more. And most pathways decussate, meaning that they cross. So the axons cross midline, so the brain processes information for the contralateral side. There is some, I think it's like 10% of nerves in a tract, maybe ipsilateral, but the large portion of them are going to be contralateral. So contralateral meaning innervating and receiving from the opposite side. Okay, so those are just your spinal pathways, motor descending, sensory ascending, and then these common characteristics that they all share. So when we're talking about these pathways as we go into this, this next session kind of is going through different pathways and reflexes in the spine. So just kind of keeping this in mind, that these are some of the basic characteristics of all spinal signals. So sensory input is transmitted through the spinal cord. It originates from general sense receptors. And there are 2 categories of those. So sensory input transmitted through the spinal cord to the brain, from the body to the brain. It originates in general sense receptors, not specific sense receptors or special sense receptors like your tongue or your eyes or your nose. These are general sense receptors all over your body. There are somatic and visceral. Again, should not be a surprise. Somatic ones are regulating your body or detecting changes in your voluntary musculoskeletal body. There are tactile and proprioceptors. The tactile receptors detect the characteristics of an object, the different shapes, the textures of it, and the proprioceptors detect stretch in joints, muscles, and tendons. Okay, so you have tactile receptors detecting different features of an object, and then proprioceptors that are going to be monitoring the position of your body and joints. Your visceral receptors are detecting changes in organs, things that we can't physically feel. Okay, the different pathways for your sensory pathways. You have your somatosensory pathways, which are carrying signals from the skin, muscles, and joints, somatosensory. Viscerosensory carry signals from the viscera. And they use different neurons to relay the signals to the brain. So when we're talking about sensory pathways, we're talking about how our body collects information and then brings that into our brain to be integrated. So the way that it can do that is that it uses a series of neurons. So it's not just one long neuron that goes from your hand all the way up to your brain. It's a series of neurons that are going to be transmitting that signal. So the primary neuron, the first order neuron, has a peripheral ending, meaning that it's going to be out of the body. The cell body will be in the posterior root ganglion, and its axon leads to a secondary neuron. Your secondary neuron is an interneuron. It receives that primary input and extends to a tertiary neuron or to the cerebellum, that bottom portion of the brain. The tertiary neuron is also an interneuron. It receives secondary neuron input and extends to the somatosensory cortex of the parietal lobe. Remember, these are sensory pathways, so they're ultimately going to be going towards that somatosensory cortex in the parietal lobe, in the postcentral gyrus. Do you remember all that? Okay, so let's talk about the specific pathways now, the specific sensory pathways. The posterior funiculus medial lemniscal pathway. 5 times fast, there you go. Posterior funiculus medial lemniscal pathway. Posterior funiculus medial lemniscal pathway. All right, signals about proprioception, touch, pressure, and vibration with a 3-neuron chain. That's what it's going to be transmitting. It's going to be transmitting signals about proprioception, touch, pressure, and vibration. You will have a primary neuron that's relaying signals from the skin to the brainstem. You have a secondary neuron that will then go from, and when it says brainstem, it specifically means the medulla, right? You will have a secondary neuron that relays from the medulla to the thalamus. And then from the thalamus, it will go to the primary somatosensory cortex in the postcentral gyrus. That means integration is place for sensory information. So as we go through these 3 pathways, this is basically the information that I'm going to want you to be able to know. With each pathway, what is it delivering signals about? There you can see my finger. What is delivering signals about? Where, how many neurons are there? Is it a 2-neuron pathway? Is it a 3-neuron pathway? And where is each neuron going to be? The primary neuron, it's going to go from your skin, it's those peripheral endings, to the brainstem, to the medulla specifically. For the secondary neuron, it's going to be from the medulla to the thalamus, and then from the thalamus to the postcentral gyrus, that somatosensory cortex. So you should be able to kind of follow that for each of these pathways. This necessarily, if you like to look at the structural view of it, go for it. Okay, the anterolateral pathway. So in the anterolateral pathway, it's conducting signals related to crude touch, pressure, pain, and temperature. Its primary neuron is going to go from the skin to the spinal cord as well. Its secondary neuron goes from the spinal cord to the thalamus. And then its tertiary neuron goes from the thalamus to the cerebral cortex. And to the primary somatosensory cortex. Making sure I don't want you to know anything else on this. No. Okay. So we had this one talking about, this one does relay signals due to touch and pressure. This is going to be more for crude touch, crude pressure. So just talking about the different ways. It's hard for us sometimes to think that, oh, when I touch something, it's not just one receptor that's relaying all its information. This water, it's cold. So I have some receptors that are detecting the temperature. I have some detectors that are detecting, okay, is this, crude touch? So is it hard or is it soft? Is it squishy or is it not? Is, the pressure, at this point, I'm the one that's putting pressure, but maybe if I, set this under my hand, let me see if I can do this without dropping it. Now I have different receptors that are activated, detecting the pressure, the weight of this onto those sensory receptors. So depending on the type of information that we're gathering, it's not always one neuron, it's not always one type of receptor, and it's not always one pathway. That information has different physical tracks that it follows to get to our brain. So for this one, your primary neuron is skin to spinal cord to thalamus, thalamus to cerebral cortex. There it is. Okay, this last one is the spinocerebellar pathway. So these names, I don't think that we got into this as much, but the names really do tell you a lot about it. Spinocerebellar, it's going from the spine to the cerebellum. See, that's where we end up. If something is named starting with spino, that means that it's going to be a sensory pathway. If it starts with spino, that means that the signal is coming from the spine up to the brain. And that means it's an ascending tract. That means it has to be a sensory tract. We'll see that the motor tracts, the motor pathways, are going to start with cortico, relating to cortex, relating to the brain, and those are going to be the descending pathways. But if you see a pathway that's named spino something, that means it's an ascending sensory pathway. So spinocerebellar are talking about proprioception within a 2-neuron chain, not a 3-neuron, but 2-neuron chain. The primary one goes from the skin to the spinal cord, and the secondary goes from the spinal cord to the cerebellum. Some of those will cross, while some may ipsilateral. Yeah, that's good. Okay, so now the motor pathways. Those were the sensory pathways, now the motor pathways. Motor pathways control effectors such as skeletal muscles and glands. They start in the brain, and they include at least 2 neurons. You're always going to have at least 2 neurons with a motor pathway, an upper neuron and a lower neuron. The upper neuron is in the motor cortex, cerebral nucleus or brainstem nucleus, and it contacts the lower one. The lower motor neuron is in the cranial nerve nucleus, spinal cord, and anterior horn, and it excites the muscle. There can be other neurons in between here. These could be a chain of neurons, but essentially that's what you're going to have. You're going to have your upper neuron in the cortex, your lower neuron exciting the muscle. Within these 2 neurons, within this basic pathway of these 2 neurons, you can have different ways to get there. So you can have a direct pathway or an indirect pathway. In your direct pathway, it's directly between the brain and the skeletal muscles. It begins with upper motor neurons in the primary motor cortex. The axons move through the different parts of the brain and the spine, and it synapses with a lower motor neuron in the anterior horn of gray matter. So it's essentially upper neuron right to a lower neuron. And then that lower neuron extends to a skeletal muscle. So it's a very much step-by-step, direct pathway. There are 2 different types of direct pathways. I think it's just 2, yeah. The lateral corticospinal tract, so again, corticospinal, so going from the cortex to the spine. That means it's descending, that means it's motor. The lateral corticospinal tracts innervate the upper motor neuron, yeah, there he goes. The lower motor neurons innervate the limb muscles for skilled movements. So limb muscles, arms and legs, for skilled learned movements. Juggling, unicycling, hula hooping, whatever it may be, whatever your skilled writing, I guess, is a more common one that we all do. Those skilled movements are going to come from this lateral corticospinal tract. The anterior corticospinal tract have lower motor neurons that innervate your axial skeletal muscles. So not your appendicular like your lateral corticospinal tract, but your axial like your anterior corticospinal tract. Then the indirect pathways. So we had the direct, those were the 2 direct pathways. The indirect pathways have upper motor neurons originating in the brainstem, and they take a very complicated route to the spinal cord. It's not just this one and done. The lateral pathway, the lateral indirect pathway, regulates precise movement and tone and flexor limb muscles. So the limb muscles, the appendicular muscles that do flexion, it regulates precise movement and tone of those. It has rubrospinal tracts. You don't have to remember that necessarily. The medial pathway regulates muscle tone and movements of the head, neck, proximal limb, and trunk. Okay, so you have your lateral pathway going to the flexor limb muscles, your flexor appendicular muscles, your medial pathway doing movements of the head, neck, proximal limb, so meaning close like to the upper arm, upper leg, and your trunk. It also has 3 individual tracts that I'm not going to get too specific into. You can read more about them in your book if you would like. Okay, so those were the different motor pathways. Direct and indirect, upper neurons, lower neurons. Good luck. Now getting into general distribution of spinal nerves. So talking about everything before this was all about the structure of them, how they conduct their different signals, how the different pathways that spinal nerves take, and now we're actually going to get into the specific spinal nerves and how they branch and group. So after the intervertebral foramen, the spinal nerves split. So after you leave that little hole in the side of the vertebrae, the spinal nerves will start to split. You get a posterior and anterior ramus. Posterior is smaller, anterior is larger. The posterior is going to innervate muscles of the skin and back. Muscles and skin of the back, sorry. The anterior ramus, it's going to innervate the anterior and lateral trunk, upper limbs, lower limbs, and it participates in plexuses, which the plural is not plexi, it is plexuses. And these are, we'll see, nerve groupings, basically. There are also the rami communicantes. These are small branches of autonomic fibers, so specifically for the autonomic nervous system. They extend between the spinal nerve and the sympathetic trunk ganglion. So we'll look more into this when we get into chapters 15. But this is essentially a sympathetic trunk ganglion. So ganglion meaning cell bodies, neuron cell bodies. Sympathetic nervous system, and trunk refers to it just refers to a chain. So running right along the side of the spinal cord. I'm trying to do this without you. Still see me. Running right along the side of the spinal cord is essentially this chain, this kind of beaded chain of sympathetic nerve ganglion that is just a stop space, basically. It helps to regulate sympathetic nervous signals out to the body. So the rami communicantes, that's part of that specifically. So if that is kind of confusing for you, this fact that we have these three different branches, just don't let it be too confusing. Just understand that your spinal nerve is going to split, and it's going to split into potentially three different regions. So here you have this anterior ramus going right here. There's your smaller posterior ramus going that way. And then your rami communicantes and the sympathetic trunk ganglion. So this is just one of them. They, and again, we're looking kind of from a superior view when we look at it this way. So you can just imagine these right here on either side, just 31 of them up and down. Or however many there are. I can't remember how many there are. Okay, dermatomes. So segment of the skin supplied by a single spinal nerve. So as those spinal nerves split, they will start to innervate different structures. And a dermatome is a segment of skin supplied by a single spinal nerve. There is some lap in the innervated regions, but what they do is they can help to localize damage to one or more spinal nerves. Essentially a dermatome says that, as you go out along your body, your nerves are going to be innervating specific points along your skin and along your muscles. So if you have numbness or anesthesia at a certain point on your skin or a certain point in your body, you can then relate that back to a spinal nerve to determine any type of trauma or damage. Spinal nerves are also involved in referred visceral pain. So appendicitis pain is often referred to the T10 dermatome. So even though the appendix is more in the inferior portion of our abdomen, we typically feel it more in the middle upper. Here is the dermatome map, is what they call them. So you can see it's all kind of numbered. The C1 does not have a dermatome. We start with the trigeminal and then C2. And as you go down, each one of these sections is saying, okay, so this section right here of your skin, or rather of your torso, all the way around is related to this T2 nerve. So if you're having any kind of anesthesia or any kind of loss of sensation in this portion of your body, that might be something for a neurologist to say, okay, let me check that nerve. And you see we've kind of mapped it all throughout the body. Okay, so a nerve plexus. What is a nerve plexus? Nerve plexus is a network of interweaving anterior rami of spinal nerves. Remember, the anterior rami is just saying, okay, that's the portion of the spinal nerve that split off. It was that larger portion. You have a interweaving, so they're just kind of all joining together. I say joining loosely because they join and they split. They join and they split. There are four main plexuses in the body. You have your cervical, brachial, lumbar, and sacral plexuses. Individual rami branch repeatedly. Damage to one nerve or spinal segment does not deprive a muscle or skin of all innervation. This is just a redundancy factor in our body, so that way you're not relying on one spinal nerve to do everything because it splits so much and because these nerves group and separate and join and separate. You have multiple spinal nerves that are involved in innervating different structures. And I should say spinal segment. I like the spinal segment better than spinal nerve. Okay, so looking at the intercostal nerves, there was a lot of information on intercostal nerves from your book. I'm kind of parsing this down. Intercostal nerves are located between the ribs. Hopefully that's easy to remember, intercostal. And they include the anterior rami of spinal nerves T1 through T11. T12 is subcostal and it's inferior to the ribs, the T12 nerve. That's what I want you to know. So the anterior rami of which spinal nerves, T1 to T11. Where are they located? And they innervate the ribs. They innervate the intercostal muscles. These cervical plexuses, they are the anterior rami of C1 through C4, so not C5, but C1 to C4. It contributes a few axons, but it's not really included in this. The branches innervate the anterior neck muscles, skin of the neck, portions of the head and shoulders. So your cervical plexus is innervating the upper portions of your body. Nothing wild. From the rami of C3 to C5, it gives rise to the phrenic nerve, innervating the diaphragm. That's a very important nerve. It runs down the side of the chest, and it helps to contract our diaphragm so that we can breathe. Okay, there is just, your cervical plexus. The brachial plexus, this one is a little bit more complex in structure. So it is from the anterior rami of C5 to T1, so cervical 5 to thoracic 1, not very big. But it has a lot of different fibers and networks. So it's composed of anterior rami, trunks, divisions, and cords. Like I said, if you read through your book on the brachial plexus, it gets very intense. There's a lot of splitting and joining around vessels and structures. We're not going to get into, I'm not going to have you get into that intense with it. I want you to know what nerves it's coming from, what nerves the brachial plexus arise from, and we'll see in the next slide some more stuff. So the rami unite to form trunks in the posterior triangle of the neck. The posterior triangle of the neck is a border from your sternocleidomastoid, your SCM, your clavicle, and your trapezius. So that little triangle that gets made right here, that's your posterior triangle. Your anterior triangle is your SCM, it's your trachea, your jaw, and your SCM. So you have your anterior triangle and then your posterior triangle. So your brachial plexus is going to be coming out of your posterior triangle and then down to your arm. It's going to innervate the anterior and posterior parts of the upper limbs. So it splits into 5 terminal branches. You should know these. You should know, if you can learn the specific muscles and specific parts of your arm that they innervate, that is great. That will be great. But you should at least be able to tell me what 5 terminal branches the brachial plexus has, or be able to identify them. So the axillary nerve to the deltoid teres major muscles, and sensory input from the superolateral arm. So axillary, axilla, armpit. The median nerve, anterior forearm muscles, thenar muscles, that's your thenar. Lateral lumbricals are kind of in between the fingers. And sensory input from the palmar side and dorsal tips of most fingers. The musculocutaneous nerve, muscular muscle, cutaneous skin. Radial nerve is the posterior arm muscles, triceps, posterior forearm as well, and sensory input. Remember, these are mixed nerves. Your ulnar is the anterior forearm, intrinsic hand muscles, as well as some sensory input. So here's your what your brachial plexus, again, just from these C5 to T1, you can see, like I was saying, they join, and then they split, and then they're going to join down there somewhere, and they're going to split again. It's very, very confusing. That is kind of seeing that whole limb view. A lot of times numbness and tingling in the fingers. As a massage therapist, I deal with that a lot. I deal with a lot of people that have issues with nerve sensation in their hands. Almost always is coming from the brachial plexus. It's some kind of impingement. Either the muscles are really tight through the upper neck. There's the scalene muscles in the upper neck that can get really tight. The pectoral muscles can start to lock down. You see they run in front of the scapula. So if the pectoral muscles are really tight, the rotator cuff muscles get really tight. Frozen shoulder, deltoid issues, that can all cause numbness and tingling down into the fingers. And depending on which fingers are tingling, you can start to identify, okay, which specific nerve is it, because we can track it that well. All right, your lumbar plexus, so keep them going. From L1 to L4, this is going to have a couple of different splits. You have your femoral nerve, which is the main nerve in the posterior division of the plexus, and your obturator nerve, which is the main nerve in the anterior division of the plexus. Femoral will be innervating anterior thigh muscles and input from the anterior thigh, whereas the obturator is medial thigh muscles and skin. There are also some smaller nerves that innervate the abdominal wall and external genitalia. Like that. Limb anatomy, and this one. Okay, here's a good one too. Your sacral plexus, L4 to S4. There are anterior and posterior divisions. Anterior innervate the flexor muscles, posterior innervate extensor muscles. And this is a general trend for the body. I think I mentioned this when we did our muscle chapter, that flexion occurs in the front of the body, whereas extension occurs in the back of the body. The only part that's not true is in the knee, where the knees extend forward and flex backwards. But for the most part, this is the trend that you'll see. Anterior flex, posterior extend. Wait. I think I got that backwards. Anterior, yeah, no, that's right. Anterior flex, yeah. Okay, your sciatic nerve. We have probably all heard of the sciatic nerve. You most likely have experienced some sciatic pain, especially if you're over like 20 or 25. You've probably experienced some sciatic pain. It is the largest and longest nerve in the body. It's formed from portions of the anterior and posterior sacral plexuses. It splits into both your tibial and your common fibular nerve. These run down your leg as they go down. The tibial nerve is not just on the tibia. It's on the lower portion of the leg, but it will innervate the hamstrings and part of the adductor muscles. And the common fibular nerve innervates also one of the hamstrings, the biceps femoris muscle. So here you can see the L4 to S4. This big conjoining right here. This is your sciatic nerve. This is that just large nerve that causes so much kind of stabbing, sharp pain right on the glutes. It runs down the back of the hamstring, kind of down the middle of the hamstring, and then at the knee, it actually crosses to the side, and that is because of this common fibular nerve. The common fibular nerve right here starts to wrap around to the outside. So the classic sciatic pain is that it starts up here, kind of off to the sacrum. It runs down the middle of the back of the leg. And a lot of times for people, it'll just kind of be right here. For most kind of acute sciatic pain, it's just going to be in this kind of more superior portion. If it's chronic and it starts to get really bad, and personally, the way that I define bad sciatic pain is that it starts to go not just down your leg, but it starts to go past your knee into this outer calf. And once you start getting pain down your outer calf and across the top of your foot, that's really bad sciatic pain. You need to go see a chiropractor. You need to go see an orthopedist, a doctor at that point usually, to be able to relieve your pain. Because what I can do as far as massage therapy and a lot of physical therapy, that type of intense pressure will probably be more than you need. You need some kind of indirect treatment to be able to relieve pain at that point. Okay, characteristics of reflexes. So we said that the other function of our spinal cord was to participate in reflexes. So if you still need another minute with nerve plexuses, go back to that. We're moving on. So reflexes are rapid, pre-programmed involuntary responses of muscles or glands to a stimulus. A reflex is a survival mechanism. This is not something that we have to think about. This is not something that goes up to our brain. We can take the time to come back and oh yes, now I'll react. But these are instant, or as instant as we can react. You have to have a stimulus to initiate a reflex. A response is going to be rapid, involving a chain of only a few neurons. Sometimes it's only just a sensory neuron and a motor neuron. There's not even an interneuron in between. The response is pre-programmed, so it's always the same. We'll see 4 spinal reflexes that we're going to get into, and they have very predictable patterns. We know exactly what's going to happen. I think a lot of people think reflexes, they do think about like pulling away from something sharp. There's also, when the doctor goes and they hit the top of your quad tendon to extend your knee. That is a very common reflex. We're all going to have the exact same response to that every time. Unless there's some type of neurological issue. The response is also involuntary. No intent or awareness of the reflex before it happens. It is completely involuntary. So here's what we call the reflex arc. So it's a neural pathway responsible for generating the response. You start with this stimulus. It looks like somebody has a nail, I'm guessing, going into their skin. That's a violent stimulus. It's traveling up this sensory nerve through the posterior root, the ganglion, into the spinal cord, where it will synapse with an interneuron that will then send information out this anterior root through a motor nerve to initiate some response, some effector response. Again, this is kind of the most basic, or one of the most basic. You have a sensory neuron, one interneuron, and then a motor neuron. You don't always need an interneuron. There are some reflexes that go directly from this motor neuron right to the sensory neuron and skip the interneuron. That happens. What you also see here is that this interneuron, while the sensory nerve innervates or synapses here, and that synapse is with this effector, there's also this other branch that's sending a signal somewhere else. And this can be going to other interneurons for different supporting responses, and we'll see that in a moment. Okay, so reflexes vary and can be classified in different ways. So 5 different ways to kind of classify reflexes. Is it spinal or cranial? Is this initiated from the spinal cord or the brain? Is it somatic or visceral? Is the effector a somatic skeletal muscle, or is it cardiac muscle, smooth muscle, or a gland? Those are easy questions. Monosynaptic or polysynaptic? Do sensory neurons synapse directly with motor neurons, or are there interneurons in the reflex arc? This is one that you would have to actually know the structure of the reflex arc to be able to determine. These two you could easily tell on your own. And this one, you know, if I gave you well, let me finish. Ipsilateral or contralateral, so is it affecting something on the same side or the opposite side of the body? And is it innate or acquired? Are you born with this reflex, or do you develop it after birth? So if I give you a reflex, if I say, hey, here is the pathway, here are the neurons that are involved, here's what's happening, you should be able to answer all of these questions for me. Or if I gave you a reflex, or if I said, hey, tell me a spinal reflex that affects the visceral body, monosynaptic, contralateral, and is innate, I would expect you to make something up. You know, or if you can know a reflex that's just like that. Again, we're going to go into 4 examples. So if I said, hey, give me a reflex that follows these criteria, you should be able to come up with one. So yes, there's your monosynaptic, again going from sensory to a motor neuron. Polysynaptic has this interneuron in between, at least one interneuron. Okay, so the different spinal reflexes. The 4 common spinal reflexes are the stretch reflex, the Golgi tendon reflex, withdrawal reflex, and the crossed-extensor reflex. So stretch and Golgi tendon reflexes use proprioceptors, those receptors in the joints that help to determine our position and the position of our joint, the extension or flexion of our joints. There is a thing called a muscle spindle, which is a proprioceptor that detects stretch in a muscle. So you have within your muscle, so here's my biceps, within the muscle, there are these things called muscle spindles that are helping to detect, okay, how much stretch is being put on this muscle at this point. The spindle contains what are called intrafusal muscle fibers that are innervated by gamma motor neurons and wrapped by sensory neurons. This is all kind of confusing without a picture, and there's a picture on the next slide, so I'm just going to read through this and then we'll get to it. Fibers not within the spindle are extrafusal muscle fibers innervated by larger alpha motor neurons. So you have your extrafusal muscle fibers on the outside wrapped around, which are innervated by alpha motor neurons. So extrafusal fibers, alpha motor neurons. Within your extrafusal fibers, within your muscle, you have these intrafusal muscle fibers that contain your muscle spindles. So your muscle spindle is the intrafusal muscle fibers, and those have gamma motor neurons. Okay. What the gamma motor neurons are going to do is that they actually, they will stretch the intrafusal fibers. So within your muscle, so inside of the extrafusal fibers, you have these muscle spindles, and they have their own intrafusal muscle fibers. These gamma motor neurons are going to stretch the muscle spindle so that it's already a little taut. So that way, when the alpha motor neurons go to innervate your extrafusal muscles, because the muscle spindle is already a little bit stretched, it will be even more sensitive to changes in the muscle length. Okay, if the muscle spindle didn't have these intrafusal fibers and these gamma motor neurons to go ahead and pre-stretch it, it wouldn't be able to actually provide a reflex. It would be changing at the same rate that your extrafusal muscles would, and it would only be able to send the signal to stop stretching when it was too late. Because that's what this does, is that this reflex is intended to help contract muscles when we start to stretch too fast. So if your muscle spindle wasn't already stretched a little bit before your extrafusal muscles started to stretch, then it wouldn't be able to give us any kind of heads up. So the intrafusal fibers, here we go, I'm gonna go right to this. So these intrafusal fibers within your larger extrafusal fiber, muscle fibers, are what are gonna be detecting or regulating your stretch reflex. So intrafusal fibers surrounded by gamma motor neurons. extrafusal fibers surrounded by alpha motor neurons. And then around the intrafusal fibers, there are these sensory nerve endings that are sending signals to the spinal cord about the stretch reflex. So the stretch reflex is the reflexive contraction of a muscle after it is stretched. The reflexive contraction of a muscle after it is stretched. Stretch is detected by the muscle spindle proprioceptor. When stretched, the spindle's sensory axon fires impulses that are conducted to the spinal cord. The more a muscle is stretched, the more signals the spindle's sensory axon is going to be sending, it's going to be firing. So if you remember our neuron lecture, it's going to increase the frequency of its signal, which is going to increase the graded potential, which will make sure that an action potential occurs. In this case, it would be an inhibitory action potential because you're trying to, it would be an excitatory action potential because you're trying to contract a muscle. In your spinal cord, the sensory axon excites alpha motor neurons of the same muscle, causing contraction. So again, the intrafusal fibers are just within the extrafusal fibers of that muscle. So the sensory neurons wrapped around that muscle spindle and its intrafusal fibers will go to the spinal cord. As that muscle spindle, as the entire muscle stretches, the muscle spindle stretches a little bit faster because remember those gamma motor neurons have the muscle spindle taut. So as your muscle stretches, that muscle spindle fiber will continue to send these sensory signals back up to the spinal cord. So that way there's this constant loop, this constant regulation of, okay, here's how much we're stretching now. Oh, now I'm sending you a lot of signals, we're really stretching. Now I'm sending a lot of signals, we need to stop. And then you have this excitation signal that happens. Once that signal, once the muscle spindle fiber starts sending enough signals, the frequency happens enough, you're going to get this excitation of alpha motor neurons, which will cause contraction in the extrafusal fiber, the full belly of the muscle. Simultaneously, while that is happening, there is this thing called reciprocal inhibition that is going on. So the sensory axon excites interneurons that inhibit motor neurons of the antagonist muscle. What that means is, how can I get my arm in here? I'll do this one. That makes more sense. So as I'm trying to contract my biceps muscle, my triceps is relaxing. That is reciprocal inhibition. What's happening is that, let's say, I was stretching my bicep and for some reason I started to stretch it and it stretched too much. I have to then immediately, my muscle spindles are going to say, okay, well, this has to contract. This muscle has to contract. But remember, for an agonist to contract, its antagonist has to relax. So our body has developed this wonderful system that while this other reflex is going on, while the stretch reflex, this muscle spindle and spinal cord are talking, there's also these interneurons that are going to be in play, going to the antagonist muscles, sending inhibitory actions to them, so that way our muscles can contract. Also, if I'm stretching my biceps, if I'm lengthening this muscle, what has to contract? The triceps has to be contracting. So sending these inhibitory signals not only allow for this muscle to contract, it also stops the stretch on that agonist muscle. It also stops the stretch on the muscle. So two different kind of things happening right there with that reciprocal inhibition pathway. Stretch reflexes. So a stretch reflex, it's spinal, it's somatic, it's monosynaptic, it's ipsilateral, and it's innate. So it's spinal, it involves the spinal cord. It's somatic because it's involving our voluntary skeletal body. Monosynaptic because it's the reciprocal inhibition. This is a polysynaptic response, but the stretch reflex itself is monosynaptic. It is ipsilateral, so it is operating on the same side of the body. And it is innate. You don't have to learn. This is not something that should be memorized. This is something that you just are born with. We've already done this little thing. Okay, so the Golgi tendon reflex. It's another good one. The Golgi tendon reflex prevents muscles from contracting excessively. So I always joke that this has never been an issue for me, but if you like to pick up a lot of heavy things, if you're a big weightlifter, sometimes what will happen is you go to pick something up or you go to a bench press and it's so heavy, the weight is so much, the tension on your muscles, specifically at where the tendons meet the bone, where you have muscles form into tendons attached to bones. If you're trying to pick up something that's so heavy, but it's not it's not so heavy that you can't even move. It's like you're trying to pick up a house where nothing's going to happen. Let's say, you try to do like a big heavy bench press. I'm not even going to try to guess weights because I don't do that. But it's so heavy that you can do it a little bit, but it's not enough because you don't have enough strength and you just collapse and you just drop it on your chest. That is your Golgi tendon reflex in action. It's also why you're always supposed to have someone spot you when you're going to start doing weightlifting or especially heavier weights, because you can't control this. If you try to lift something or pick something up or move something that is beyond your ability, your body will physically stop you. So the Golgi tendon organ detects excessive tension on tendons. It basically makes sure that we don't rip our muscles off of our bones. They're proprioceptors with sensory endings at muscle-tendon junctions, so where muscles, the muscle-tendon junction is just where muscles attach. Their sensory axons excite interneurons in the spinal cord. Some excited interneurons and inhibit motor neurons of the same muscle. So it's happening to the same muscle. So it's polysynaptic. You have these interneurons that are in play, so it's a polysynaptic reflex. And then some excited interneurons excite motor neurons of antagonist muscles, inducing reciprocal activation. So this is the opposite of reciprocal inhibition, where the signal was saying, no, you need to relax, the antagonist needs to relax. This is saying, no, you need to engage, because when our antagonist engages, our agonist will relax. And that's what this is trying to do. It's trying to make sure that we don't, again, just pull our muscles off of our bones. It will make you drop things if it's too heavy. Here is that Golgi tendon organ reflex, Golgi tendon reflex. Again, the Golgi tendon organ is within the tendon of the muscle. Muscle contraction increases tension to tendon detected by Golgi tendon organ. Your muscle contraction stimulates sensory nerves that travel to the CNS. This is going to go through, it's a polysynaptic, so it's going to go through an interneuron, travels out your motor neuron, and it causes relaxation of the agonist, contraction of the antagonist. Okay. The withdrawal reflex. The withdrawal reflex pulls the body away from a painful stimulus. This is what we think of when you typically think of like a reflex, touching something hot, something sharp, jumping away from something. Those are the withdrawal reflexes. Stimulus excites nociceptor sensory neurons that transmit signals to spinal cord and excites interneurons. Nociceptors are pain receptors. That's just the fancy name for pain receptors, is a nociceptor. Those interneurons will excite motor neurons of flexors. So flexor muscles, like your hamstrings, contract and the limb is withdrawn. Again, it's the flexor muscles. You're not going to withdraw and use your extensor muscles and push things out. You're going to flex back. You're going to draw back. So your flexor muscles are going to be activated. Simultaneously, other interneurons reciprocally inhibit motor neurons of extensors, so the extensor muscles relax and withdrawal happens quickly. Again, these things are kind of happening simultaneously. The crossed-extensor reflex is paired with the withdrawal reflex. So what happens is you have some interneurons excited by the nociceptor sensory neurons cross midline and excite the extensor motor neurons on the other side. This helps to allow us to shift our body weight. Because again, if you think, you're walking down a path and you see a snake or something, or let's probably say it's probably a stick. It's probably not even a snake. You see like a stick and you kind of jump back. What happens if it's over here on this side, you're going to pull back, but all of your weight will shift to that other leg to help hold you. So while you have one side of your body going through the withdrawal reflex and all of those, you have your flexors engaging, your extensors relaxing. On the crossed-extensor reflex, you have this you have your extensor muscles being excited to help brace you and support you in this transition of body weight. Here is that representation of the cross-extensor, withdrawal and cross-extensor reflex. Again, always starts with a stimulus. So painful stimulus detected by sensory neurons, goes up the body, traveling this blue line through the posterior ganglion, the posterior root, and into the gray matter where it is processed. And then again, you have this interneuron following your withdrawal reflex. And then this other interneuron initiating your crossed-extensor reflex. So if I gave you this chart, you should be able to tell me, or if I give you like this chart, or if I gave you the same kind of scenario, you should be able to tell me which muscles are involved, or which pathway is your withdrawal one, which one is your crossed-extensor, or if I were given an example about, you're walking down a path and there is something to your right side, Tell me, which muscles are going to be, or which side of your body will exhibit crossed-extensor reflex, which side will exhibit the withdrawal reflex. You should know that if there's something to your right side will have the withdrawal reflex. Your left side is going to have this crossed-extensor reflex to help brace you and support you. Okay, reflexes are useful in clinical testing situations. They can test the function of specific muscles, nerves, and spinal segments. If you have hypoactive reflexes, they're diminished. If you have hyperactive, they're abnormally strong. Hypoactive could indicate damage to your spinal cord, muscle disease, or damage to your neuromuscular junctions. Hyperactive, again, damage to the brain or spinal cord, especially if accompanied by clonus. Clonus is, this is one of those interesting things. If you Google, if you look up YouTube videos of clonus, you'll see what happens is that, like, pretend that this is, we'll just say it's this. So if I hit that reflex, when someone has clonus, you kind of hit the reflex, and then their whole arm or their leg or whatever will just kind of start shaking. And it just kind of is persistent and kind of happens. And then you can actually, one of the quickest ways to relieve it is to put pressure back on that tendon. You have to relieve the pressure off of the tendon, and the clonus will stop. But you typically see that especially in people that are a little bit more older, that have deteriorated nervous systems. Their body just can't really regulate the reflex properly. It kind of gets stuck in that contract-relax cycle. Development of the spinal cord. I'm going to be very straightforward with this, just one slide. You have your neural canal, because the development of the spinal cord is much more simple compared to the brain. By the 6th week of development, you have this limitans forming. Yeah, I'm putting this information up here. What I really want you to understand is that during fetal period, growth of the vertebral column outpaces growth of the spinal cord. That's why your spinal cord stops at about L1, whereas your vertebrae keep on going. The rest of this stuff, read it. Right, and there's this picture, again, just showing that development.